Hello everyone, I'm Sang-Chul. It's great to see you again. Today's topic is easy bone grafting procedure after ailing implant fixture removal using 330 bar. As always, the surgery was performed by Dr. Chung. Through today's procedure, you will learn how to perform right implant placement and fixture removal on a narrow anterior mandibular ridge. Before starting today's surgery, let us take a closer look at the previous case. About the previous session, we got the anterior lower, another surgeries here. His chief complaint was, my temporary front tooth flipper broke and I would like to replace it with an implant. So Dr. Chung did extraction and bone grafting and adding the collagen graft and the installed bright tissue level, diameter 2.5, 11 millimeter. These photos are pre-op situation of our patient oral cavities, and the remaining teeth was number 41, 42. So extract all of these teeth and then put the implantation, as you know. Before cone beam CT was here, number 42 area and 32 area. Very narrow ridge and labial bone plate is so thin, so it is not able to have regular diameter internal connection type on this ridge. So we want to have another option to install this ridge. So finally, Dr. Chung decided a bright TL on this area. As you know, as you can see, this situation was after installation. Diameter 2.5 and 11 millimeter bright TL system was installed on number 32 and 42 area, covered with collagen graft and sutures. And what is next? The bright oral pack to cover all of this surgery site. This one is post-op panoramic view and post-op CT view. What about this? Very nice and exact, precise installation on this narrow anterior area. What about number 42? Very nice installation just before the cortical bone plate, both of sides, vocal and lingual, and same as number 32 area. However, this platform was 3.8 millimeter, so strong, so enough strong to have a strong connection on this for implant bridge supported by 2 implant fixture. After that, we're going to get the intraoral scan like this. This intraoral scan taken by in the clinic on the day of surgery, the same day of surgery. After installation, we can see clear the lower anterior 2 implant was installed, number 32 and 42 area. And after surgery, we got the scan data here and send to the CAD for making a temporary provisional restoration. The STL file sent to our this program, and we can make the ideal position for supported 4 unit bridge supported by 2 implant fixture bright TL. Healing situation after 2 days of surgery, very nice, well done. Epithelialization was ongoing. This is 1 week after situation of the surgery field. The provisional restoration was delivered to our patient mouse on number 42 and 32 area. The hole was incisor. Why? Because of this provisional restoration, the first priority is easy retrieval, right? So after insertion and retrieval is a main point to make a temporary provisional restoration. That is why to make an incisal, the screw hole. After 5 months, the healing period was gone and connect with a digital abutment. And after connecting a digital abutment, we gonna take another, the intraoral scan. Sometimes for taking accurate the scan data, we make a small the flowable resin added on this edentulous, the mucosal area. Especially long span case, this resin marker is so helpful to have to make accurate scan data, right? So in this case, make one resin marker was made between two implant fixture site and have a scan taken STL file to send the rep, and this is real data, resin dot marker data. So this flower resin marker data demonstrate more accurate compared to without this resin marker. So if you can, you can use this the technique, the resin marker technique on the edentulous area, on the mucosa area. Okay. And sometimes we're going to use this vertical articulator for accurate occlusion scheme. Finally, we got this kind of final restoration and the milling sintering. We always use bright 3-layer zirconia block for make this final restoration. The very simple and easy procedure to make a final restoration in case of zirconia block. And the custom, in this time, the custom abutment was made, connected with this the ready-made zirconia 4-unit bridge, and the SCRP type was installed, and the screw hole sealed with the composite resin. Now, what about this scheme? Actually, this lower, the anterior 4-unit, the anterior bridge was very well done and installed on this narrow ridge. At the first time, you can find out some bright black triangle between the artificial teeth, for example, number 41 and 31 area. And also we can see this black triangle between the lateral incisor and canine area. However, in the times going, this black triangle reduce the size. And in some case, if you want to have more aggressive and active treatment for reduce this black triangle, you want to inject the filler, right? For me, actually, I frequently use the filler injection, this kind of the black triangle situation after insertion of final restoration. Okay, this one is final process is PA, very nice and well harmonized. The final restoration and implant fixture. Marginal bone was still very healthy and remaining there very well. And final process is the Combeam CT view case, number 42 and 32, gave us a good health situation on the marginal bone and the soft tissue relation. The final restoration was good. Okay, follow up 2 months after insertion, the installation of final restoration. We can see this, the marginal gingiva. What about this marginal gingiva? I think very thick and healthy marginal gingiva, the keratinized gingival band, located on this implant and implant the crown implant bridge area. However, actually I want to reduce this black triangle area. So as I mentioned before, you're going to use filler also. This one is one-off treatment as a one-off treatment option. Okay, 2 months follow-up PA, very nice, well done. Okay, Conbeam CT was there, the same as before. In conclusion, the previous surgery procedure gave us one lesson, right? Even though the narrow reach area, the simpler installation with bright TL using collagen graft and collagen the bone is an easier way to restore the edentulous narrowed lower anterior reach. So, what do you think about the diameter? Actually, as you know, 3.3 internal connection type is the minimum size of fixture diameter. And sometimes we're going to use, in some special case, 2.8 millimeter. However, 2.5, even though the 2.0 is useful and available on your clinic, impossible. It is not able to use this smaller diameter than the narrow diameter, 3.3 or 3.5, right? However, if you choose a bright TR system, we're going to use 2.5, even though the 2.0 and 3.0 is available, right? That is main key factor from the previous surgery procedures lesson. Okay, let's move to today's surgery. Patient information. Our patient today, 79 years old female patient, her chief complaint was, I have soreness in the lower right gingiva. And past dental history, implant placed at many implant placed on number 26, 36, 33, 34, 36, 37, 44, 46. The last of implant already installed, and the root canal treatment on number 16 area. And past medical history was the cancer surgery, so she currently taking medication. That is today's surgery's patient intraoral view, the pre-op situation. What about this lower anterior? The keratinized gingiva is almost gone away already, and just mucosa and the narrow ridge and resolved areas, the very poor condition. What is your choice? What is your plan about this sort of lower anterior narrow area? This one is pre-op panoramic view. One implant, the buried, the slit on this number 33 area. It means teaching us the lots of history about this lower anterior, right? Okay, 43, 32, 33 areas bone, CT scan, cross-sectional view, narrowed ridge, and the alveolar bone was resolved already. And number 33 areas, the ailing implant was there. The buccal bone was gone away, so it is impossible to have I think this one is impossible to helping the superstructures after another new implant installation. Surgery plan is as follows. Removal of the existing implant fixture at number 33 due to buccal bone loss. Bone and soft tissue grafting using osteogeno as a bone graft and collagen membrane, hard type, as a barrier membrane, and also applied collagen graft 1D for the open healing procedure. Implantation at number 43, a bright tissue level 3.011 millimeter, and another one will be installed on the 32 area, diameter 2.5 and 11 millimeter. About the tissue level, the bright implant system, as you know, a 20-degree external bevel system. This one is external connection. That is important first thing that you have to remind about this implant system. External connection, 20-degree external bevel. And platform is 3.8 millimeter, one single platform system. And the gingival height 1.5 polished surface with a concave. This one is for the soft tissue. The under controlled design means the soft tissue room for the healthy connection between hard bone and soft tissue. This area is very important and more important nowadays, as you know. Dome shape. And about bone graft, as a bone graft, osteogeno will be applied on this defected area. This osteogeno from the bovine cancellous bone, right? So what is the difference between the brand or the previous system, the bone grafting? Actually, osteogeno came from the bovine. However, the almost cancellous bone. That is more faster turnover. It means a softer and the faster turnover means a faster new bone formation, right? So easy to nesting the bone cells and easy stabilization of a bone cell and the vascularizations, the faster. And also, finally, we got the new bone formation faster than any other the xenograft material. The collagen membrane. The collagen membrane have two different types, as you know, hard one and softer one. Today, the hard type collagen membrane will be applied. This hard type collagen membrane is conventional, the traditional type, the more resilience and stiff, a little bit the longer, long-lasting, the more than 6 months. That is an important characteristic if you want to use this barrier membrane for the GBR, the successful GBR procedure, as you know. So the collagen membrane hard type is enough to conserve these defected areas, bone grafted area. Okay, another one, the biomaterials will be introduced on this trade surgery, collagen graft. This one is nowadays the faster growing in our market. Actually, doctors and especially in normal dentist, the general dentist, want to use this collagen graft. Cause of this collagen graft compensate open healing technique, and sometimes we're going to get some wound open situation after GBR procedures or some another complex procedures. But however, this collagen graft to compensate this open wound situation. So compared to the barrier membrane, this collagen graft is better, getting better to get the faster the epithelialization, faster soft tissue healing. Today, Dr. Chung may use this collagen graft combined with collagen membrane hard. We're gonna get the lessons and the tip of the procedure. How can I deal with this collagen graft? Big GBR procedure. Okay, let's move to today's surgery. the more detailed information will be given during the surgery video, right? Now, Dr. Chung make a crestal incision using number 12 scalpel, step by step. The crestal incision was made. The lower jaw portion, the crestal incision, is most popular. However, the upper jaw, the maxillary area, a little bit deviated the incision on the crestal area is popular. For example, on the maxillary posterior area, maybe 2 millimeter deviated from the middle portion of the crest to palatally make a crestal incision. That is more comfortable to handle the flap manage. Why? The upper jaw, especially posterior maxillary area, the palatal flap, palatal soft tissue thickness is thicker than any other part of soft tissue zone, especially compared to buccal and the palatal area. As you know, the palatal soft tissues are thicker. So the almost 2 millimeter deviated to palatal, the palatally inclined deviated the crestal incision. Actually, this para-crestal incision is more useful to manage the flap, the reflector flap, and then to make some the osteotomy, and sometimes you're going to make the handle for the crestal approach for sinus elevation. All of these situations are able to have when you have the paracrestal incision on the maxilla. However, the lower jaw, mandible, the mid-crestal is the general crestal incision, the scheme. As you can see, the mid-crestal incision was made, and the reflector flap and the lingual flap was reflected here. And about number 33 areas, the varied installed implant exposed, right? With the cover screw. As I mentioned before, for the lower anterior, these mandibular areas gave us a lot of history about the treatment and procedure. Why? They already installed these 33 areas. And another opposite side, the edentulous and the thin, the narrow ridge. When the patient came to our clinic, this patient was edentulous situation, edentulous manner on this lower anterior. Before then, actually she got already implant treatment, supported the bridge on these areas. I don't know exactly the reason, the how, due to some reason the failed implant was happened and removed already this number 43, maybe 42 area, and just remained this number 33 areas was installed implant fixtures still there, still remaining there. So on this sort of situation, if this remaining implant fixtures like number 33 is already installed here, these implant fixtures helping a new implant supported bridge. In this sort of a case, you can use this fixture as a supported manner. However, not going to help him to make a new bridge. Removing this implant fixture, that is answer, right? So what about the labial surface? Actually, the 4-5 millimeter implant, the surface was exposed on the labial area. It means in concern of long term, the follow-up for the long-term follow-up, I think this implant fixture is not helping anymore to supporting a new implant supported bridge. So remove this ailing implant is answer. Okay, now Dr. Chung used number 330 bar. 330 bar is very versatile. Actually, long shank 330 bar that make some indentation on the cortical bone plate like this one. Why this long shank 330 bar instead of Lindemann drill? High cortical bone plate area, even though the high speed of Lindemann drill sometimes easy to slippery, right? So before using this Lindemann drill, the high speed bar is very useful to make an indentation on the proper site, especially in the thick cortical plate area, right? So as you see, first, high-speed bar, the small indentation, and after that, they're using a Lindemann drill and take a position with the parallel pin. Wow, very nice. So parallel, like a machine. Dr. Chung is always make a good positioning like here. So I think due to the numerous experience about the implant surgery. So always, even though the freehand type, the manual type, osteotomy case, very similar to use the surgical stent style. However, in beginner or the general dentist, sometimes using the surgical guide is helpful to make a proper positioning on this narrow ridge. Wow, already installed this number 42 area, diameter 2.5. All the implant fixture surface surrounded by host bone. That is main key to using bright PR system, right? All the implant surface surrounded by host bone. These implant fixtures thinking down the host bone bed, right? Now, diameter 3.0. The excellent installation. The osteotomy procedure is so simple. Did you see the drill procedure? High-speed, small indentation, Lindemann 1, and final drill, and then installation. Just only 3 drill and implantation. Number 2.5 diameter case, actually 2 drill is enough to have osteotomy and installation. So already done, 2 implant fixtures installed on the very accurate, the precise installations accomplished on this plant site. Now, Dr. Chung is going to use 330 bar to make some trench around this, the old installed implant fixture. The buccal plate was gone away. So make a small trench. And that is know-how. How can we deal with, how can I remove these failed or ailing implant fixtures already installed? So there are many different ways to remove implant fixture. However, this kind of procedures are simple, faster, that everybody have done like this one. When the implant fixtures should be removed, right? A small tip elevator located between implant fixture surface and make a trench area and a little bit small luxation like extraction of natural tools. And when we have some mobilities using this small root forceps, can be applied for removing implant fixture. Even though the little bit wide diameter and long body was installed on this very thick area, however, so fast to remove using this 330 bar, high-speed bar, long shank bar, that is very versatile and useful tool to removing the already done installed implant fixture. After that, remove plastic cap. This plastic cap, the working, the protection manner, right? The purpose of plastic cap is protection. The screw hole, the inside of the top portion of fixture. Removing plastic cap and connect with the scan comfort cap now. You see the some of notch here. This notch for the scanning, right? This scan comfort cap, the working as a healing abutment, and the region is a scanning, like as a scanning jig. So sometimes this scan comfort cap using as a temporary abutment for temporary processes. Very versatile abutment. Now, the osteon geno was filled on this defect area. 33 big defect was filled with osteon geno, the bovine xenograft matures. Okay. After filling with osteon geno, the particulated bone graft on this defect number 33 and 42 area. Okay, now that he's preparing the collagen membrane, hard type. As I introduced you, this defect was a 3-wall defect, very comparable defect. The contained defect. This contained 3-wall defect is the good situation to make a new bone. So in this sort of case, the particulated bone with the collagen membrane as a barrier membrane is a good combination. Very nice combo. So another part also applied with collagen membrane. This contained defect is easy to get apply the collagen membrane. Sometimes you can use pin fixation or the periosteal releasing incision and periosteal suturing. And however, sometimes just to put and the lab around this, the defected area is enough. The cause of the stiff buccal flap is holding the stiff buccal area of collagen bone, and the stability is enough getting for this stiff flap and the tugging between the flap and bone area. In case of a three-wall defect, like a contained defect like this, right? However, if you want more, you want more getting the stability on this area, so you're going to use the pin fixation, using the pin or the peristal suturing. Okay. After that, make a small hole using a punch and connect with a collagen graft with this skin comfort cap. Okay. Like engagement ring, this collagen graft was applied top portion of the comfort cap. Why use this collagen graft additionally on the upper side, the collagen membrane? Okay, now he's make a small peristal releasing procedure using this periodontal curette. He is scoring the periosteum using this periostal curette to make the periostal releasing, right? So make some room after applying this bone grafting and the collagen graft for the more intimate closure during the suture. Okay, this additional collagen graft working as the faster the wound healing, right? The vascular driven the epithelialization, that is correct term for the explaining using this collagen graft. The vascular driven the epithelialization will be achieved when we use the collagen graft. This collagen graft, the holding the blood clot and some of the activating the cells to make a new bone, the bone cells and the plasma and the blood, and finally blood vessels engage this collagen graft, and finally make a faster the epithelialization. It means faster soft tissue wound healing, right? So this phenomenon I can explain as a vascular driven the epithelialization. So it means if even if wound flap will be open, never mind anymore, cause of this collagen graft to protect this opened area to promote the faster soft tissue healing. That is why they use this collagen graft, the top of the barrier membrane. This collagen membrane working as the barrier membrane to protect underneath graft materials until to make a new bone formation, until transforming new bone formation, right? So at this time, the flap exposure, some shrinkage during the healing period, the flap by shrinkage, right? So the little bit the tangent, the suture during the suture, maybe tangent, not tangent freestyle, maybe a little bit the collapse and shrink, the collapse down to each another direction. the wound will be open, a little bit smaller, and then this collagen graft protect this open wound area. And that is why to use collagen graft on this area. Even though the primary closure, the intimate primary closure case, tangent will happen and the flap shrink during the healing period, as you know, right? And also this kind of areas, muscle tone, will be worked. So this the flap margin will be open. However, once more, this collagen graft working as a barrier. So this collagen graft promote the faster soft tissue healing based on vascular driven epithelialization. Okay, the surgery will almost done. And he need more interrupted suture. Before this, modified the horizontal matrix sutures was applied on this area, already done. Now interrupted sutures will be applied here. Can you see between two implant fixture? The colors and graft exposure. However, the flap, even though the flap open, this colors and graft will be worked. So never mind about this open wound.
실밥 풀을 때 한 10일쯤 있다 실밥 좀 풀을까요? 네. 그러면서 그때 스캐닝해서 위치 아주 작업을 합시다. 아니면 2주 있다 실밥 풀으면서 네.
So Dr. Chung is going to have a scanning for this patient after 2 weeks at the time point of stitch out, and make a scanning and take a file, and then make a temporary prosthetic procedures. Prosthesis will be applied for this patient. Okay. How simple the procedures it is. Actually, even though the 69 years old female patient, almost 80. So what to think about? You want to make some big incision with horizontal and vertical incision, and then the full thickness prep and the periosteal releasing incision, and then make a big bone graft around these lower anterior areas with implant fixation. If you choose like an internal connection type, maybe 3.3, even though the 2.8, maybe implant fixture thread will be exposed, and you need more effort, like a big bone graft and make some the space maintaining. For this purpose, make some sometimes screw engaging is a necessary part, and the collagen membrane should be covered, all of this GBR, the area. That's so complicated procedure. That is not good for the elder patient. However, today's surgery is simply done and very faster for the patient. Actually, this kind of procedures is suitable for the elder patient like this person. with a simpler way and helping a good implant system. The good implant system like a Bright TL helping the implant surgery is simpler than before and also doesn't need anymore the big periosteal releasing incision. The cause of open healing technique was available for using this collagen graft, brand new regeneration material. Okay, I think this nut is final. Good, very well done. All the procedures are simple, as you can see. Okay, very nice. And thank you for watching. We will have 5 minutes break, and then we will get the Q&A session. Thank you. Thank you for waiting. Now let's move to post-op view. The bright oral pack was applied after suture. This bright oral pack is self-released, self-resorbed the material. So very easy to and useful. The protection, the surgery site, and the post-op panoramic view, the very nice parallel implant to implant fixtures was installed on 33 and 32 and 43 area. The diameter 2.5, 3.0 as you know. Okay, 33, 30, 43, 32 is a target area for the today's implant surgery. So what about 33? These areas removed all the implant, the ailing implant fixture, and then put the bone graft materials, osteon geno, the xenograft material, and covered with collagen membrane site, GBR site. These areas will be very nice newborn formation after maybe 4 or 5 months later. So after that, if you want adding more implant fixture, you can use this site, number 33, right? That is another option. In the younger person, that is necessary part one. Sometimes you need consideration another one more implant fixture. However, the elder person like this 78 years old, almost 80 years old female patient doesn't need any more. Just only 2 implant is enough to support for anterior bridge. Okay, now we have a question, a Q&A session here. I'm gonna have the questions. Very nice, a good question. Thank you. First, number 1, can the canine be used as a cantilever with a bright tissue level implant? Of course, yes. Normally, the canine area is very important, as you know, the canine guidance or the function group, the guidance with the occlusion scheme. On natural dentition, this canine is important corner tools, as you know. However, the implant system is totally different. Actually, these canine areas can be cantilevered, right? The implant mechanics a little bit different compared to natural dentition. So some case, this canine portion can be skipped, right? So finally, my answer is yes, I can. Okay, the make a canine as a cantilever, especially elder patient, as I mentioned before. These areas, if a complicated area, maybe should be skipped, and the neighbor areas is enough to make 4 unit bridge implant supported 4 unit bridge. Let's see. Can you remember during the surgery procedure, Dr. Chung the first implantation on number 32 area before the removing the neighbor, the ailing implant fixture, right? Why? Because of this area is very important, like natural dentition's canine portion, right? So he don't want any bone loosening. Let's see, after removing the implant, the ailing implant, all implant fixtures, and then the bone grafting or the installating, make osteotomy. Let's think about this osteotomy. Maybe during the just only 2 drill, even though the two drilling, maybe this distal bone plate, the squeezing, the distally, cause of this area is void, right? So Dr. Zhang doesn't want any more this area's bone loosening or the loosening the bone. He want to get the higher initial installation. This area is very important, right? So after inserting this implant bright TL, the implant fixture installation, this 32 area, and then removing the ailing implant, right? That is one of the reasons to make a procedure. Okay, number 2, what are the advantages of using collagen membrane heart during bone grafting procedure? Okay, a good question. Basically, when you have a GBR procedure, right, the main two sources, we need the main two sources. First one, bone graft materials. Another one, barrier membrane. As you know, the bone graft materials, there are many different types and different kinds in our market. However, four the main sources. First one, autogenous, and the xenograft and allograft, alloplastic and allograft, right? Once again, autogenous, allograft, xenograft, alloplastic material, right? And about this membrane, the non-resorbable and resorbable membrane. Nowadays, actually, this resorbable collagen membrane is prevailed, as you know. This membrane have two different types. First one is have some the soft and resilient. Another one is stiff and hard. Both of collagen membrane have a different characteristic and different good point. However, this hard type is long lasting. First one, long lasting. So it is suitable for a bigger defect, like a big defect, 2 or even though the 1 or defect, we need more time, like more than 6 months, 7 months case. Actually, you should use this long-lasting hard type collagen membrane, right? So we need some long-lasting. Another one reason is space maintaining. This stiff membrane gave us a space maintaining. Some without another devices like a tenting pore or some devices. So self itself have self space maintainable the characteristic. However, this one is softer and the resilient and the collagen membrane. It is suitable for a small defect. And also, you can use like a sausage or the same kind of technique. You use this resilient collagen membrane. However, generally speaking, this resorbable membrane, the soft resorbable membrane, is a faster resorption period, faster resorption time, maybe 2 and 3 months. It is not enough to have a big defect bone grafting situation to make a GBR procedure for a long time, long lasting, for long time successful the result, right? So that is why to use collagen membrane heart, Dr. Chung want to have perfect and good qualities bone, even though to contain the defect and familiar situation to make to transforming the new bone formation around this area. He want to make guaranteed these areas transforming new bone formation with high quality, right? In this sort of situation, condition, you have to you have to decide to use collagen membrane heart type. Okay, that is my answer. Okay, thank you for watching today's surgery video, the monthly surgery video. Okay, next time we will have another surgery. The videos will be held on the August 21, the same time, 7 o'clock in Korean time. Thank you for watching again. See you next time. Bye.